Assalamu alaikum students. Today we are going to cover the second part of the physiological anatomy of the respiratory tract, and in this session we are going to learn about the parts of the lower respiratory tract. We will learn about the blood supply and the nerve supply of the lungs, and we will learn about the pleural membranes and the muscles of the respiration. So we will begin with the parts of lower respiratory tract. Lower respiratory tract is formed by the trachea, bronchi and the lungs. So you can see in this diagram the trachea, the two main branches, the right and the left bronchus, and the bronchial tree which arise from these bronchi, the main bronchi, and the lungs are the parts of the lower respiratory tract. Now trachea, along with its bronchial tree, it is like an inverted tree. The trunk of this tree is trachea, while bronchi are its branches. And this inverted tree, it ends up as alveoli, which are the air containing sacs or the most terminal portions of the lungs where gaseous exchange is going to take place. Now we are going to discuss the important structural characteristics of different parts of the lower respiratory tract, and we are going to begin with the trachea. Now trachea is a rigid tube that has C-shaped cartilages in its wall. These cartilages are or the cartilaginous rings are deficient posteriorly. The ends of these cartilages are connected, or we can say that between the ends of the cartilages are present the bands of smooth muscles. The presence of cartilages make the trachea rigid and it prevents the collapse of the trachea. Now trachea divides into two main branches, the left and the right bronchi. Here you can see in this diagram, this is the left bronchus and this is the right bronchus, which will enter into its respective lung. Now inside the lung, the bronchi will divide dichotomously. By dichotomous division, which we mean that each bronchi will divide into two branches, then each of the branch will divide again into two. So dichotomous division of the bronchi is there inside the lungs, and as the bronchi continue to divide, their diameter becomes smaller, and there are certain other changes also seen in their walls and in their structure. As the bronchi continue to divide, they form small bronchioles. When the diameter of the airways it decreases to 1 millimeter, we call the airway as bronchiole. So bronchi are the airways having a diameter greater than 1 millimeter, while bronchioles have a diameter of 1 millimeter or even less than that. The bronchioles can be the terminal bronchioles and the respiratory bronchioles. The terminal bronchioles have diameter of 1 millimeter, while the respiratory bronchioles have diameter even less than 1 millimeter. The respiratory bronchioles then give rise to the alveolar ducts, and alveolar ducts in turn give rise to the alveolar sacs. So you can see here, these are the alveolar sacs. This is the section, and this is the entire picture. How does the bunch of alveoli look like, which are attached, which are connected with the alveolar ducts. Now the epithelium of the airways is ciliated, as we have discussed in our previous session that epithelia are ciliated, and we now know the significance of ciliated epithelium. Now ciliated epithelium also contain the numerous mucus and the serous glands. Again I am repeating that epithelia of the airways are ciliated. The ciliated epithelium is present as far as the respiratory bronchiole. Till the stage of respiratory bronchiole, the epithelium of these airways is ciliated. And the other thing that I told you is the presence of mucus and the serous gland. Now mucus and the serous glands are present till the stage of the bronchioles, or we can say that the terminal bronchioles as well as the respiratory bronchioles do not contain the glands. Again I am repeating that the bronchioles, like terminal bronchioles and the respiratory bronchioles, do not contain the serous or the mucus gland, but their epithelium is ciliated. Another very important thing is that as the trachea divides into the bronchi, and then bronchi divide into small branches, the amount of cartilage in the walls of the airways, it decreases. The amount of cartilages in the walls of the airway decreases, so that when the stage of terminal bronchioles is reached, there is no cartilage present in the walls of the airways. So we can also describe it like that the airways from the terminal bronchioles or beyond the terminal bronchioles do not contain cartilage. Instead, they have smooth muscles in their walls. So as there is division of the bronchi, the amount of cartilage is going to decrease, but the amount of smooth muscles in the walls of the airways is going to increase. So the terminal bronchioles as well as the respiratory bronchioles have abundance of the smooth muscles in their walls. The respiratory bronchioles, they give rise to again alveolar ducts. Now in the alveolar ducts, the smooth muscles are not present. Smooth muscles are not present in the wall of the alveolar ducts. Similarly, the walls of alveoli are also very thin, and there is just a single layer of epithelium resting on the basement membrane, and there are no smooth muscles in the walls of the alveoli. So from trachea till the stage of terminal bronchioles, there are 16 divisions, or we can say that from it takes trachea to divide 16 times to reach the stage of the terminal bronchiole, and from respiratory bronchiole to the stage of alveoli, there are 7 more divisions. So total of 23 divisions are there from trachea till the stage of alveoli. Again I am repeating, from between trachea and the alveoli, there are total of 23 divisions. 16 divisions are till the stage of the terminal bronchioles, and from the respiratory bronchioles to the alveoli or the alveolar sacs are 7 more divisions. And respiratory bronchioles and the terminal bronchioles do not have cartilages in their wall, but they have an abundance of smooth muscles in their walls. Due to presence of abundance of smooth muscles in their walls, their diameter can be controlled by the autonomic nervous system that we are going to learn shortly. Now this table shows us the different divisions of the airways and their structural characteristics. Like bronchi, they have cartilages in their wall. Their diameter is greater than 1 millimeter. Their epithelium is pseudostratified columnar and is ciliated. And the terminal bronchioles, they do not have cartilages in their wall, but they have smooth muscles instead, and their diameter is 1 millimeter or less than 1 millimeter. Their epithelium is cuboidal. It is ciliated, but it does not contain serous or mucous glands. Then are the respiratory bronchioles. Again, they do not have cartilages in their wall. Their diameter is less than 1 millimeter. Their epithelium is cuboidal in nature, and they lack the serous or the mucous glands. The epithelium, although it is cuboidal, but still it is ciliated. Cilia are present in it. Now the most terminal parts of the airways are the alveoli. So here we can see alveoli which are attached to the walls of the alveolar ducts and the bunches at the most terminal part. Now alveolar sacs, they have very thin walls, as I just have told you that there is a single layer of epithelium in the alveoli. The epithelium of the alveoli, it contains two types of cells. Single layer of epithelium is there, and the epithelial cells are of two types: type 1 alveolar epithelial cells and type 2 alveolar epithelial cells. Now type 1 alveolar epithelial cells are flat cells, and they are involved in the exchange of gases, that is exchange of oxygen and carbon dioxide between the alveolar air and the blood present in the pulmonary capillaries. The other type of alveolar epithelial cells are type 2 alveolar epithelial cells. Now type 2 alveolar epithelial cells are only 5% of the total, while 95% are type 1 alveolar epithelial cells. Type 2 alveolar epithelial cells secrete a very important substance called as surfactant, and the function of surfactant is to reduce the surface tension of the fluid lining the alveoli, the detail of which we will learn in the upcoming lectures. Now adjacent alveoli are connected through a small openings or the pores which are called as pores of Kohn. Again I am repeating, the adjacent alveoli are connected with each other through pores of Kohns. The purpose or significance of these pores of Kohns is they are meant for collateral ventilation. Pores of Kohns provide collateral ventilation, means air can enter from one alveolus into the other alveolus. Now I will show you this in the diagram. So here we can see a section of the alveoli, and here you can see small openings or spaces. This one as well. Now these openings are the alveolar pores, and these are meant for the collateral ventilation, and this collateral ventilation provides alveolar stability. Now there is another way to divide the respiratory tree. Yesterday we divide the respiratory tract or the respiratory tree on the basis of structure or anatomy as upper and lower respiratory tract. Now functionally we can divide the respiratory tract into two parts: the conducting airways and the respiratory unit or the exchange zone. Conducting airways and respiratory unit or the respiratory exchange zone is the classification which is based on the function. Now by conducting zone or the conducting part, we mean those components of the respiratory tract which are involved in conduction of air from the atmosphere to the parts of the lungs where gaseous exchange is going to take place. While exchange unit or the respiratory unit, it includes those parts of the lungs where gaseous exchange is going to take place. Now exchange part or the exchange part or the respiratory unit of the lungs, it includes a respiratory bronchiole. You can see in this diagram, this is a respiratory bronchiole, the alveolar ducts and the alveoli. So again I am repeating this, that the exchange unit or the respiratory unit, it includes those parts of the respiratory tract which are involved in gaseous exchange between the air present in the airways and the blood present in the pulmonary capillaries, and these parts include the respiratory bronchiole, alveolar ducts and alveoli. You can also add atrium in these parts. So atrium are basically the blind pouches to which the alveoli are attached. There are about 300 million alveoli present in the human lungs. Now these alveoli are surrounded by a network of pulmonary capillaries. As you can see in this diagram, the alveoli are surrounded by a network of capillaries. Now these capillaries are also surrounding the other terminal parts of the lungs which are involved in gaseous exchange, like the alveolar ducts and the respiratory bronchioles. Now pulmonary capillaries are again they are single layer, thin, means they have a single layer of endothelial cells resting on the basement membrane. The diameter of the pulmonary capillaries is just 5 micrometer, so that the RBCs have to squeeze through the pulmonary capillaries, and this will improve or increase the efficacy of gas exchange between the blood and the air present in the alveoli. So this is a cross section showing us the different structures. This is the air sac alveolus. This is the wall of the alveolus, and you can see the capillaries are surrounding the alveoli, and here is a lymphatic vessel present to drain the lymph from the interstitium. So between the cells there is interstitial space or the interstitial tissue. Now with this we have completed the parts of the respiratory tract. Now we will move on to the next anatomical structure, which is the thoracic cavity. Why we are discussing thoracic cavity here? Just because of the fact that lungs are present within the thoracic cavity. Now lungs are present in the thoracic cavity. This cavity is closed. It is separated from the rest of the structures. Like superiorly, this is enclosed by the neck muscles and the connective tissue. Inferiorly, the thoracic cavity is bounded by the diaphragm. Diaphragm is the muscle of inspiration. While outer chest wall of the thoracic cavity is formed by the sternum anteriorly, ribs, and posteriorly there is vertebral column. So these are the boundaries of the thoracic cavity. Here you can see in this diagram, superiorly there are neck muscles and the connective tissue closing this cavity. Inferiorly you can see this dome shaped muscle. This is the diaphragm separating the thoracic cavity from the abdominal cavity. Anteriorly we have sternum, and laterally and running posteriorly are the ribs or the rib cage, and to the ribs are attached again the muscles, internal and the external intercostals, and posteriorly we have the vertebral column. Now coming to the blood vessels of the lungs. There are two types of blood vessels present in the lungs: the pulmonary vessels and the bronchial vessels. Now pulmonary vessels or pulmonary circulation is a high flow, low pressure circulation. Again I am repeating that pulmonary circulation is a high flow, low pressure circulation. The pulmonary artery, it arises from the right ventricle. So you can see this is right atrium, receiving the deoxygenated blood from entire body through superior and inferior vena cava. this will right atrium opens up into right ventricle, and from the right ventricle arises the pulmonary trunk, and which is going to divide into the two pulmonary arteries, left and the right pulmonary artery, which will enter into its respective lung. Now inside the lung, the pulmonary arteries will divide and it will ultimately form the pulmonary capillaries, where gaseous exchange will take place, and the pulmonary capillaries will unite to form the small veins, which are venules, and then the pulmonary venules will join to form the larger veins. So pulmonary veins will carry the oxygenated blood from both the lungs back to the heart into left atrium. From the left atrium, the blood will be pumped into the left ventricle, and from the left ventricle, the blood will be pumped out through aorta to be distributed to the entire body. So this is the pulmonary circulation in the lungs, and the blood flow through the pulmonary circulation is equal to the cardiac output. The other types of blood vessels present in the lungs are the bronchial vessels. Now bronchial vessels or bronchial circulation, it is a high pressure, low flow circulation. It means that pressure in the bronchial artery is high, but the flow is less. The blood flow through the bronchial arteries is only 2% of the cardiac output. And moreover, you must remember that bronchial arteries are the branches of aorta. So pulmonary artery is arising from the right ventricle, while bronchial artery, it is a branch of aorta. You can also see in this diagram, it's a branch of descending aorta, and it is a high pressure circulation. The pressures are high, but flow is only 2% of the cardiac output. Now purpose of bronchial arteries is to carry the oxygenated blood to the lung parenchyma. Lung is a living tissue, so it requires nutrition, it requires oxygen, which is supplied to the lung tissue through the bronchial arteries. Now bronchial veins will carry the deoxygenated blood. Now bronchial veins, they drain or they bring this deoxygenated blood back to the pulmonary veins. So there is mixing of the deoxygenated blood present in the bronchial vein with the oxygenated blood present in the pulmonary veins. This is about 2% of the cardiac output, because the blood flow through the bronchial circulation is 2% of the cardiac output. So this mixing of the blood, this blood which is mixed from the bronchial veins, which is deoxygenated blood, it is mixed up with the oxygenated blood in the pulmonary vein. This is called as physiological shunt. This is known as physiological shunt and is equal to 2% of the cardiac output. Now coming to the nerve supply of the lungs. While discussing the physiological anatomy of the lower respiratory tract, we have learned that there are smooth muscles present in the walls of the airways, and as the airways become small and small in their diameter, the number of smooth muscles increase till the stage of the respiratory bronchioles. Now these smooth muscles in the walls of the alveoli are innervated by both divisions of the autonomic nervous system. Now autonomic nervous system has two divisions, the sympathetic division and the parasympathetic division. So the smooth muscles have both types of receptors, that are the receptors for the parasympathetic division and receptors for the sympathetic division as well. So cholinergic receptors are muscarinic receptors, while the receptors for the sympathetic nervous system are adrenergic receptors, and mainly the beta 2 adrenergic receptors are present. Now parasympathetic stimulation will cause bronchoconstriction, which involves the muscarinic receptors, while stimulation of adrenergic receptors by sympathetic nerves will produce bronchodilation. So smooth muscles are going to relax when there is sympathetic stimulation, and relaxation of smooth muscles in the walls of the airways cause an increase in the diameter, which is called as bronchodilation. Like vasodilation is increased diameter of the blood vessels brought about by sympathetic inhibition. So here it is opposite. Sympathetic stimulation in the blood vessels, it produces vasoconstriction, but sympathetic stimulation of the airways is going to cause bronchodilation, and as well as there is increase in the bronchial secretion, while parasympathetic is going to cause bronchoconstriction, and this is mediated through the muscarinic receptors. Now there are a number of sensory receptors, rather than we should say there are a number of different types of sensory receptors which are present in the airways in the lungs. The different types of receptors present in the lungs are the stretch receptors, irritant receptors are also present in the lungs, and there are chemical receptors also present in the lungs. Now these receptors are stimulated by their respective stimuli, and they send signal to the respiratory control centers to regulate the rate and depth of ventilation. Now coming to the pleura, the next structure or the part that we are going to discuss is pleura. Now pleura is basically a seroelastic membrane which lines the thoracic cavity. It is invaginated by the growing lungs, or we can say that lungs are covered, on the outer surface of the lungs there is a seroelastic membrane which is called as pleura. Now this pleural membrane, it has two layers, visceral pleura and the parietal pleura. Now visceral pleura is attached to the outer surface of the lung, while the parietal pleura is attached to the inner surface of the thoracic cavity. Now between the two layers of the pleura there is a potential space which is called as pleural space. It's a very small space which does not contain air. It's a closed space, does not communicate with the exterior or with any inner structures of the lung. It's a closed space, does not contain air, but it contains a few ml of a fluid which is basically the lymph. This fluid is called as pleural fluid, and it is secreted by the parietal layer of the pleura, and this fluid is drained by the lymphatics. The pressure in the pleural space is subatmospheric, that is less than atmospheric pressure. Now the pleural fluid along with the two layers of the pleura, which are the visceral and the parietal pleura, and the pleural fluid, they enable the lung to slide on the inner surface of the thoracic cavity, which makes the process of inspiration and expiration, or we can say the process of respiration, easier. Here you can see in this diagram how the lungs are invaginated by the pleura, how the double layers of pleura are formed. So if we consider that this lollipop is the lung, so this water filled balloon is the pleural membrane. So you can see how the lungs are to be invaginated by the pleural membrane, how the two layers of pleura are there, and there is in between the two layers of pleura there is a potential space which is containing the pleural fluid. Now this layer of pleura which is adjacent to the lung surface is your visceral pleura, and this layer of the pleura which is facing the thoracic cavity, or we can say it is attached to the thoracic cavity, is your parietal pleura, and between this is the pleural space containing the pleural fluid. Now coming to the last topic, which is the muscles of respiration. Now in today's session we are just going to enumerate the muscles of respiration. How do these muscles work to produce inspiration and expiration? We are going to learn in the next lecture, that is our respiratory mechanics. So you all know that respiration consists of two phases, inspiration and expiration. So we have two sets of muscle, two groups of muscles, the inspiratory muscles and the expiratory muscles. The inspiratory muscles are further divided into muscles of quiet inspiration, or we can say the major muscles of inspiration, and the muscles of forceful inspiration, which are also called as accessory muscles of inspiration. So the major muscles of inspiration include the diaphragm. Here I have again previously showed you the diagram of the diaphragm. So it's a dome shaped muscle present as a partition between the thoracic and the abdominal cavity. So diaphragm is the main muscle of inspiration. Along with diaphragm there is external intercostal muscle. Here you can see the muscles which are attached to the rib cage running downward. These are external intercostal. So external intercostals and diaphragm are the major muscles of inspiration, which are involved during quiet inspiration. While during forceful inspiration, accessory muscles also contract, and the accessory muscles of inspiration include the sternocleidomastoid, scalenus muscle and serratus anterior, which is not shown here. So three muscles are there which are the accessory muscles of inspiration. Again I am repeating: the sternocleidomastoid, scalenus muscle and serratus anterior, or you can say the neck muscles are the accessory muscles of inspiration. Now coming to the muscles of expiration. All of you must be knowing that quiet expiration, or you can say during quiet breathing, the expiration is a passive process. That is, it does not involve the active contraction of the muscles. Instead, there is just elastic recoil of the lungs during quiet expiration, and air is exhaled out of the lungs. However, during forceful respiration, the process of expiration also becomes active, which means it requires muscle contraction. So muscles of active expiration include the internal intercostal muscles. Here you can see, which are attached to the inner surfaces of the ribs. So these are your internal intercostal muscles, and these are muscles of active expiration. The other very important muscles of active expiration are your abdominal muscles. So here you can see this is rectus abdominis, and these are also abdominal muscles. So two muscles you must remember in active expiration: abdominal muscles and internal intercostal muscles. So this was about the muscles of respiration, the muscles of inspiration and muscles of expiration. So I will stop here, and I hope you will understand the lecture. And if you have any difficulty in understanding any concept, you are free to ask me question. I am always there to solve your queries. Thank you so much.